with that research article that I sent you? Yeah, I thought it was kind of interesting. You were totally right.
Really interesting. Yeah, I was talking to some other friends who were trans, but like that would suck so much. Like I would literally want to die if I was like had like gender dysphoria and there was nothing.
They said the abstract said that the person was doing well, but it's hard to imagine that.
Yeah,
but.
Yeah, it's like such a case by case basis.
Yeah. Okay, so we were at uterine tubes, also called fallopian tubes or oviducts. Talk about structures and functions there. The normal site of fertilization is right here in the ampulla of the uterine tubes. That's actually the longest portion, even though it looks kind of short. It's just curved and it continues to go back there. Of course, we talked about the infundibulum and the fimbriae, right? This is the isthmus and this is the interstitial segment or uterine part. The usual site of fertilization is the isthmus. Sorry, not the isthmus, the ampulla. There are, as far as the tissue layers, the outer layer of the uterine tubes is serous membrane. Then you have a muscular layer called the muscularis, and that will do peristaltic contraction to cause the courting of the oocyte that we talked about before. And do you remember what kind of tissue lines the fallopian tubes or oviducts? It's ciliated, simple, columnar. Yeah. What's the function of the cilia here? Go ahead.
Move the egg down.
Yeah, moves the egg. It's like part of the courting of the oocyte, right? Okay. So clinical notes. So just a couple. We already talked about ectopic or tubal pregnancies, right? We already said if it implants anywhere but the inside of the uterus, it's considered ectopic, which means out of place. Tubal is a specific type of ectopic pregnancy that occurs in the tube. They generally, with very few exceptions, can't be carried to term. Okay. Let's talk about PID, pelvic inflammatory disease, very quickly. Pelvic inflammatory disease is when you have some kind of pathogen that moves from the vagina to the uterus up to the fallopian tubes, and it can even move into the pelvic cavity, into the peritoneal cavity. So it is, because the entire thing is open, if something gets into your reproductive tract, there's really no way to stop it from going wherever it chooses to go. And one of the big problems with pelvic inflammatory disease is that it can cause infertility because, of course, if you scar or irritate the oviducts or uterine tubes, they're already relatively narrow. And if you scar or injure them, they actually can't let the egg go through or can't let the fertilized egg go through. So you can either have problems with, if they get really scarred, the sperm won't go up, so you can't have fertilization, right? If they get scarred less, the sperm can still go up because they're tiny, but the egg can't get through, right? And you can't get implantation. So what are the common causes of pelvic inflammatory disease? It could be any pathogen that makes it into your reproductive tract. Again, if a little girl does not learn to wipe front to back, it's really easy to get digestive pathogens into your reproductive tract, right? And it can cause pelvic inflammatory disease. In addition, STIs, STDs, can cause pelvic inflammatory disease. You guys may or may not be aware that the vast majority of sexually transmitted infections are asymptomatic in one sex or both. So a woman can have a sexually transmitted infection. She can have no indication that she has it. However, it can be causing scarring of the fallopian tubes. So this is pelvic inflammatory disease. It's a really common cause of infertility in women. And you usually won't ever know that it occurred until you try to get pregnant. And if you scar one of your oviducts, you reduce your fertility by half, right? Because you generally have one egg per month, and it usually comes from different ovaries. It doesn't go left, right, though. It goes right, left, left. It just does whatever the hell it wants. Nobody even knows why. Okay, so let's talk about the uterus. The uterus is the womb. It is the site where you would implant and support a developing embryo, fetus, baby, all the way up. Let's talk about the parts. This is the fundus. Looks like a little trampoline, bink, up there. The fundus is the portion that is above the uterine tubes. This is the body. Okay, that's where most of it is. This is the isthmus, where it starts to get narrow. And this is the cervix. And most people don't have any idea what their cervix is, but I'll tell you about your cervix in just a second. First, let's look at the tissue that lines the uterus and talk about it briefly. Okay, so the outer wall of the uterus, called the perimetrium, is connective tissue, because you remember how, it's serous membrane, because even though the urinary bladder is sort of stuck in the pelvic cavity, the uterus is actually sort of flopping around up here. So if you look inside a cadaver and you see a floppy bag-like organ, it is not the urinary bladder, because that one's all stuck down there. It's the uterus. Does that make sense? And it's really thick-walled. Look at how much musculature you have in the wall. So the outer layer is serous membrane. Come here just a second. Outer layer is serous membrane. The middle layer is really thick muscle. It's smooth muscle, of course. It's called the myometrium. And then the inner layer, and then we'll go back up to the structures that support it. The inner layer is called the endometrium. And the endometrium actually has 2 sublayers in it, so let me just tell you just a little bit about it. The endometrium always has this bottom layer called the basal layer of the endometrium, and it stays there all the time. And then, under exactly the right proportions of estrogen and progesterone, what will happen is the basal layer will start to grow a thick functional layer. And the thick functional layer is a really vascular tissue that grows with high levels of progesterone. And what it is doing is producing a really nice vascular, hospitable place for implantation. Does that make sense? Okay. And then what happens every month when you don't implant, right? What happens is you drop your level of progesterone and then you will shed just the functional layer. Yes? And so then you'll make up again the next month another functional layer. So the basal layer makes a functional layer every single month, and then you shed it. Now, that means when a woman is menstruating, you are not menstruating fluid. You are menstruating tissue. You're menstruating vascular tissue, right? You are losing vascular tissue. Of course, it has got a lot of vascularization, so you can understand how it seems like fluid. Let's go back just a little bit and talk about the size and what the supports for the uterus. Okay, as far as the size of the uterus, if a woman has never been pregnant, the uterus stays about pear size, about the size of a small pear. In a woman who has been pregnant, it's larger. And a woman who has carried a pregnancy to term, it's going to be larger forever. Okay? So if she's carried a pregnancy all the way into the 3rd trimester or close to term, then her uterus is going to stay relatively large forever. So it never really goes back to its original size, which means that when I am doing dissections and I actually have a cadaver, I can tell whether I can't tell whether she's had a live birth, although you can tell from bones in the pelvic girdle whether she's had a full-term birth, but I can tell that she's been pregnant before. It's not very difficult to tell. Okay. Now, as far as the supports of the uterus, in addition to the support that you already learned, which is this broad ligament right here, right? I also have 2 more. This one's weird. This round ligament goes from just under the fundus of the uterus through the inguinal canal onto the labia majora. So it's like holding on to your labia down there. And why the hell does that exist? Well, it makes sense in a man, and it just develops the same way in a woman. And then this guy right here holds on to the distal end of the uterus, and then also the vagina. This is called the cardinal ligament or the transverse cervical ligament, sort of positioning everything. And then in addition, our major support, in addition to those, is that you have a floor of skeletal muscles right here. This floor of skeletal muscles are called the pubococcygeal muscles or the perineal muscles, or sometimes the Kegel muscles. And those muscles, when they are intact, help to keep your uterus up, okay? Now, those are the muscles that if a woman has a whole bunch of big-headed babies, she can rip the hell out of those muscles and she can have uterine prolapse, and her uterus can flop out, okay? It's not going to flop outside of her body, it's going to flop outside in the skin and sort of hang down here. She can also have urinary bladder prolapse, usually caused by just having a lot of children or having children without really adequate medical care, in which you sort of rip as you're going through. Okay, so we'll talk about cervical cancer in just a second. So the blood supply to the uterus, you probably aren't surprised that it comes from the internal iliac arteries, drained by the internal iliac veins. There's basically a branch off the internal iliac arteries that is called the uterine arteries. Okay, so let's briefly talk about endometriosis. and then cervical cancer. What is endometriosis? Well, I wish I could tell you a lot of answers about endometriosis. I can tell you a few facts. I can tell you a lot of questions about endometriosis. Here's what happens with endometriosis. Every month in a woman who is post-puberty, during endometriosis, what would happen is instead of the endometrium just growing inside her uterus, it doesn't respect boundaries and it starts to grow up in her uterine tubes. And then it can make it out of the uterine tubes because they're open into the peritoneal cavity. It can grow on her intestines. It can go all the way up to her diaphragm. So the entire thing is open. Here's what happens every month with a woman who has endometriosis. It starts growing on all of those places under high levels of progesterone. And then her progesterone levels are going to drop, right? Progesterone levels drop and she will menstruate. And she will menstruate from her uterus, of course, right? But then all of the other endometrial tissue everywhere else will slough off as well. It doesn't feel good when it sloughs off from the inner wall of your uterus. It feels far worse when it sloughs off of your intestines. So it sloughs off. Of course, it can't make it out via your vagina, right? So white blood cells just gobble it up. It doesn't cause infections or anything, but it's outrageously painful. And when it sloughs off the wall of the uterine tubes, it actually causes scarring of the tubes and leads to infertility. So endometriosis is one of the major causes of infertility in women. So what the hell do you do about it? Well, they try a bunch of different things. They try to give you hormonal treatments. Birth control sometimes helps, whether you're sexually active or not. Messing with your hormone levels will sometimes change it. And then if that doesn't work, then sometimes they can go and laser off some of the endometrial tissue, and sometimes it grows back and sometimes it doesn't. Getting pregnant sometimes helps. Completely screws up your hormones for a little while, and sometimes they don't go back to the endometrium stage, or endometriosis stage. When I was in college, I had a friend who had endometriosis, and her doctor, she was 19, her doctor told her that if she ever wanted to get pregnant, she might want to get pregnant now, and it actually might fix her endometriosis, which is bizarre in any state but Utah, honestly. Like, ain't nobody trying to get pregnant at 19 anywhere else in this country, right? And you shouldn't either, honestly. I am telling you the damn truth about that. Children are an awful lot of your mental energy. And if you were going to make great works of art, less likely to happen. If you were going to get a PhD, less likely to happen after you get pregnant. So that's endometriosis. It's really not well known what the hell is going on there. Sometimes in the later stages, if it's been tried every other thing, they will take out your uterus. Sometimes that doesn't even work because you've still got the tissue growing elsewhere. Sometimes they have to take out your ovaries too. So a radical hysterectomy, complete hysterectomy. Okay, so last disorder, and then we will get to the vagina, is cervical cancer. So gentlemen, you may or may not know this, but it's time for you to learn. When a woman goes in for her annual exam, one of the things that they do is they take a little toilet brush, right? It ain't comfy. It's a little brush, and it's not even soft. And they shove it up the vagina, and they stick it in the cervix, and they scrape cells off the cervix because the cervix, epithelial tissue of the cervix, has a relatively high rate of cancer. But it's a very slow growing cancer. It's not very aggressive. So if you catch it when it's just getting started, it's very likely that the woman will live. So what she has to do is have a pap smear. And a pap smear looks for abnormal cervical cells. The primary reason that cells become abnormal, other than just chance, because cancer can occur anywhere, is that there is a very, very common sexually transmitted infection called human papillomavirus, which is usually asymptomatic in women. It's mostly asymptomatic in men too, but in either sex it can also cause genital warts. It can also cause other kinds of cancer. But in women, exposure to HPV can long-term increase your likelihood of cervical cancer. So what they do is they scrape the cervix, and then somebody who paid attention in histology looks at your cervical cells versus normal cervical cells under a microscope and says, this is what they should look like, and this ain't right. Do you see how weird the nuclei look? How abnormal the nuclei look? How they look like they're going through mitosis pretty dramatically? This is an abnormal pap smear, and you'll get a thing back that says you have an abnormal pap smear, and then they'll check again to make sure that it was actually abnormal. If you have either precancerous cells or cancerous cells, it's still not a death sentence because it's a very slow-growing cancer. So they can layer them off, they can do surgery to take them out, and then they will just test you more frequently to make sure it actually doesn't go into full-blown cancer. Or even if you had cancer, you usually survive from it. So what happens, this is the third most common gynecological malignancy, but it's the 8th leading cause of cancer-related deaths in women, and it's usually young women who died historically of that. So what they did is they said, okay, if you want prescription birth control, you will have a pap smear when you come in to get it, even though pap smears don't have anything to do with prescription birth control, right? They're just rooking us into taking care of ourselves. So you have to get it, right? Every single time you get it scraped. So annual pap smears increase the likelihood of detection. More than 50% of women who get cervical cancer have never had a pap smear. Go ahead. It's after you've had positive, not necessary for the cancer, but for the precancerous cells. So it's after you've already tested this way. So this is a less invasive mechanisms. Okay, so let's talk about cervical cancer just briefly, and let's talk about what's going on in Utah, and let's talk about vaccination. So there is now a vaccine for most forms, I think 8 of the 12, I can't remember what the stats are. There's several different versions of human papillomavirus, and there is now a vaccine that is effective for the vast majority of them. FYI, if you are sexually active, you will probably get exposed to HPV. It is extremely common, and STDs are way more common in Utah than they are in most places, as is generally true with states with abstinence-only education. People don't really protect themselves. They pretend that sex is not going to happen, and then when it happens, they don't protect themselves. It is going to happen, FYI, in one way, shape, or form, right? Okay, so there's a vaccine. It's called Gardasil, and it is available, maybe you remember now. I think it's available for girls of 11 to 27, is that right? 11 to 24, okay. After 24, they haven't tested it yet, and they probably figure you have it anyway. Not cancer, just HPV, okay. And then boys, is it 12? I thought it was 12 in boys.
I'm not sure, but I think it's like 24 to 23.
Okay, so in Utah, believe it or not, it's actually, and not just because of the anti-vaccine movement, this is actually relatively controversial. I talked to my gynecologist, who's a high-risk gynecologist. He's also a research gynecologist, and I was like, hey, what the hell's going on here? Why is this controversial? And he says, do you really want to know the truth? And I'm like, hell yeah, let's talk about this. And he said, well, it's because here in Utah, whenever I suggest it to parents, they say, but my daughter is going to be a virgin when she gets married so that she doesn't need it. And I was like, well, she's going to have a partner. He's going to be a virgin too. FYI, point 1, people lie. Like, that's literally what people do about sex. It's like all we do about sex. I've never masturbated. I don't know that person. Whatever. You just lie, right? Point 2, so if she has sex, you're okay with her getting cancer because of it, right? You're like, oh yeah, cancer's fine, but you have to be a virgin, right? So what he told me, which was just shocking and kind of heartbreaking, is the appeal that he uses for Utah parents who are resistant is that he tells them that even though your daughter may be a virgin when she gets married, what if she's sexually assaulted? And he told me that that is actually one of the most effective appeals that he's managed to do, which is like kind of heartbreaking, right? It's absolutely heartbreaking. And even worse in Utah is trying to get the boys to be vaccinated because they don't have a cervix, right? But they're the carriers. And FYI, HPV also causes penile cancer, just not as frequently, right? So you like your penis, right? Go ahead and get a shot, right? My little boy's already had his shot, and I was like, do you like your penis? He's like, it's fine. Because he's 11, it doesn't really do anything good yet. It's like, whatever.
Do you have to go like to your gynecologist to get this done?
No, you can get it done at a pediatrician. You don't even have to have a gynecologist yet, because you don't have one when you're 11, right? So pediatricians will do it if you ask your parents. Of course, if you are under 18, you're going to have parents involved in the process. So they actually get to make the decision, even though you're going to be the one who deals with the consequences when you're an adult. So this may be a time in which you can advocate for the things that are important to you. Because there's no guarantee that whatever partner you get, they will not have been exposed, right? Go ahead.
I remember getting mine done. You had to get certain shots for like junior high, and they just did it along.
Oh yeah, that is not required.
Oh,
It's not required, huh? It's not one of the things that you like have to have it to get back into school, right? They don't require it at all anywhere in the country. And we have the lowest, our state has the lowest rate of HPV vaccine compliance in the country. Shocker. Right? So, yeah. So you guys can make your own decisions about that, especially when you're parents. Okay, so let's talk about the vagina. Because everybody's interested in the vagina. Either you came out of one or you're figuring out how to get back into one way or the other, right? One way or the other. Okay, so you got to be able to find it. That's number one. That's what I'm doing for you. You can ask your future partners to write me a thank you note. Clitoris, vagina, both very important. Okay, so multiple functions of vagina. Expel the unfertilized ovum through the vagina. It's, of course, the birth canal, and it receives the penis and the semen during intercourse. Make sure that you can find it on a mid-sagittal section. Don't get the tubes screwed up, either on a test or otherwise. Very, very bad. So this is a vagina, urethra, vagina, anus, and rectum. Okay, so let's look at the parts. Not a whole lot of parts of the vagina. This is the vagina, and this part right here that surrounds the cervix is called the fornix, because somebody figured out, I don't know how the hell they figured this out, I've never actually looked it up. They figured out that the fornix right here has lots and lots of sensory nerve endings, so they thought it was really good for fornication, but I don't know who the hell gets up there. I mean, I guess it's nice to have a goal, but I don't really think that most people actually access that part, right? So, I don't know. That's called the fornix. Okay. And then if you look at the vagina, here is a post-mortem dissection of a vagina fresh. Here is the rugae. This is the fornix. This is the cervix, right? So you can see the rugae. The rugae and the vagina are, of course, for stretching when you have to stick a baby through it, right? But then, of course, the wrinkling, the folding of the vagina also increases friction on the penis during intercourse to increase the likelihood of ejaculation. So it's like a double, right? Double functionality. Okay. So as far as the tissue layers of the vagina, the inner layer, do you guys remember? The inner layer of the vagina is made of moist stratified squamous epithelium. Yeah? But it's a specialized moist stratified squamous epithelium that can produce and secrete glycogen into the vaginal lumen. And then the glycogen gets slightly fermented, so the vagina is slightly acidic when it's healthy, which means the acidity makes it less hospitable to bacterial infection. That makes sense? It's like a protection. And as long as the pH of the vagina stays about how it's supposed to be, then it's really not very hospitable to bacterial injections. If you take a bunch of medication, if you get on antibiotics, then sometimes it can screw up the pH, and you can get opportunistic infections in your vagina that you wouldn't otherwise get because you're sort of screwing with your chemistry a little bit. It's not at all uncommon, and if you take medication and that occurs, go to the doctor because it's actually pretty easy to fix in the early stages. Usually it's like getting rid of the bacteria and resetting the pH of your vagina. Okay, so the middle layer is smooth muscle. Of course, will contract both during orgasm and also during childbirth. And then the outer layer, remember that the vagina is really kind of stuck into all this connective tissue. So the outer layer is not serous membrane. It's connective tissue. So it's adventitia. My phys professor called the vagina the hostile vaginal vault, because it's hostile to bacteria. It's also hostile to some sperm and some semen. There are some people whose body fluids do not like one another. So that's probably natural selection telling you not to have a baby with that person, right? If your body chemistry is like repelling one another. One of the reasons that we know that occurs, not the only reason, is that people and mammals who are closely related, their body chemistry tends to be really similar. And when your body chemistry is really similar, it tends to have kind of violent responses when you get near it, which is why, let's just imagine that you've got a sibling who everyone considers objectively very sexually attractive. But to you, they smell like farts and pickles, and you think they're disgusting. In addition, what often happens as a mammalian protection mechanism is even if you did have sex with that person, your hostile vaginal vault would make it unlikely that there was a fertilization event. It's a protection mechanism against inbreeding. It's really common with mammals, actually. In addition, it can also really irritate your vagina. I told these guys the other day that my sister-in-law dated somebody for 10 years, that every single time they had sex, her vagina sloughed off the inner layer of her vagina. I was like, there is no man that is funny enough or clever enough or rich enough for me to have to rebuild my vagina every time, right? I was like, and then they ended up breaking up. I was like, should have happened ages ago. The opening to the vagina is the vaginal orifice, and you guys can find it on a picture, right? Okay, this is going to be really important. Probably going to be on your test like this. I almost posted that on the quiz, and then I thought, I'm going to imagine one of these guys taking that quiz with their parents in the room, and I don't want that to happen, so I posted a mid-sagittal section instead. But when you're in class, your parents ain't here. Okay, so make sure you can find the opening to the vagina. Make sure you can find it here as well. So I want to talk about something that's in your that is not in your textbook for reasons I don't understand. This one is actually even not controversial about its existence, and it's got cultural and historical significance. So I want to talk about the hymen. So what is the hymen? The hymen is a vascular membrane that covers the vaginal orifice, usually partially, to varying degrees at varying times in a woman's life. So I'll show you 4 different kinds of hymens, but there are about 20 different variations to hymens. Okay, so this is a normal hymen in which you've got this vascular membrane that covers the opening of the vagina. Then you can have one that's called an imperforate hymen. It's not really imperforate, it's microperforate. So if a woman had an imperforate hymen, she would, instead of menstruating for a few days each month, she might menstruate for 3 weeks because it would take an awful long time for all of that tissue and the fluid to get out through the microperforations. Here's, that's imperforate. A microperforate has little, that one has little holes in it. This one's got one big hole in it. And then the septate one, but there's all different variations. So let's talk about what is true and what is cultural and what is historically significant, because this is kind of interesting. So still today, many cultures, including some cultures that are in the United States, use an intact hymen as proof of a woman's virginity, okay? Which is kind of an archaic term anyway, still used. So what would happen in cultures that still use that practice is before the woman is considered marriageable, she has to have her hymen inspected. Now let's talk about the ways in which you can rupture your hymen. You can, of course, rupture it with sexual intercourse, right? You can also rupture it with masturbation. You can rupture it with insertion of a tampon, or you can rupture it with like almost any kind of sports activity, right? In which you might actually do a lot of this, for instance, right? So it's really easy to rupture the hymen. Well, I shouldn't say it's really easy. It's not difficult to rupture the hymen by non-sexual activities, right? So historically speaking, this has been used as evidence of a woman's virginity. There is nothing comparable that has been used as evidence of a male virginity. It was so historically significant and still is that Queen Elizabeth, I think it was the first, the Virgin Queen? That was the first, right? No, she can't be the first. Yeah, Queen Elizabeth the first, might be the first. Even though she was monarch of, at the time, arguably the most powerful country, in order for her to not have to abdicate the throne, she had to have the royal surgeon inspect her hymen every single month, or else she actually had to step down. She had to never have sex in order to keep the monarchy, because she was also considered the head of the church when she was doing that. And in Western Europe during medieval times, it was not uncommon for, after the wedding night, for them to hang out a bloody sheet as evidence of a marriage well made. That makes sense? And now still to this day, there are cultures in which the hymen is inspected. There is even a specialty within plastic surgery that does a replacement of the hymen, in which you actually take tissue from elsewhere and actually replace the hymen so that it looks like it's still intact. So now, let's talk about what can happen if a woman has a relatively thick, imperforate hymen, and she doesn't know that she's supposed to have a vaginal opening, right? And her partner doesn't know either, because they've both been educated by abstinence only, ignorance only education. And then they have their marriage night, working everything perfectly, and then the hymen doesn't rupture, because some hymens are so thick that they have to be surgically ruptured before you can have intercourse. So what will happen in a situation like this? Well, in at least 3 literature articles, what can and does happen is that they end up having sex through the urethra, which is not stretchy, not meant for that, causes recurring urinary tract infections, causes urinary incontinence, but what usually makes them finally go to the doctor is that they can't get pregnant. Well, yeah, you can't get pregnant. It's in the wrong hole. So this is always my argument, and I'm considering, as soon as my son finishes the school that he's in, running for school board. And I'm going to argue this one every single time when they tell me we need abstinence-only education. Go ahead.
I had a coworker, and she was very young, and she was getting married, and we had conversations about, obviously periods and whatnot, and her wedding night, and what was going to happen and stuff, and she was saying that she can't even insert a tampon. She doesn't like them anyway, but she says that after she had a marriage, and she had to have surgery. Is that the surgery?
She probably had a very, very closed hymen. Yeah. And it's a really simple surgery. It's a really simple surgery. It's just like a slice, then some healing, right? Numbed, slice, healing, then later, after healing, you can have sex. But most women are not like this. This is a really, really small percentage. But if you were like this and you don't have any education about what your reproductive tract is supposed to look like and function about, right? I mean, I told you I was 12 and I didn't know there was a hole there. I thought you had babies out of your butt when I was 12, right? That was before the internet, people. Don't be critical. Okay? But not by the time I was having sex, right? By the time I was having sex, I'd figured a couple things out. But I suspect this is an editorial comment. Dismiss it, as you do with most of my editorial comments. I suspect that part of the problem is that people tend to assume that ignorance about sexuality has something to do with morality or virtue. But it's just ignorance. It's just like the facts actually exist and you just don't know them. It doesn't make you any more or less likely to be moral, from my perspective. What was your question, Corey?
I just read an article over the weekend, and it was about like women. I don't remember what country it was, but it was like a very. It might have been like an Islamic country. I don't know for sure.
Okay.
But they were like inspecting women who wanted to serve like as a nurse or in the military, and they would like check if her hymen was ruptured by like fingering her, and that can rupture your hymen.
Oh my heavens.
I know, and so like I just thought that was horrible.
I hope that you guys are the generation that this business goes away. Because you shouldn't be rummaging around on anybody's genitals unless you got a hell yes and a high five. Really. You should just like back the hell off, right? That's amazing. Okay, so now let's get to males, because males are important too, right? Okay. I am going to change your notes one more time because I realized that I put the old version of the sex response in there, because your textbook, even though one of the authors is my friend, Valerie, they wrote all of the stages of the male sexual response in your textbook. Go ahead and flip and look for the phases of the female sexual response.
I noticed that and I was curious about it.
They are not in there, and I've talked to Valerie about it twice. And so what I did is I wrote them up. I pulled them from the literature and I wrote them up, and I'll just post that little addendum to you guys, whether you want to, I'll tell you whether I'm going to test it. Probably bonus question. How about that? You want to write a bonus question about male and female sexual response? Yeah? Okay. So I wrote it up, but I forgot to put it in this version of the notes, so I'll post it for you. And if you want to study it, you can. If you don't, you don't have to. Okay, so let's talk about the male reproductive system anatomy. And I won't finish, so I will post a 20-minute lecture for you guys afterward. It's the same material, so you've already looked through it because you're going to look through it for your quiz anyway. I just didn't quite have enough time to finish. So let's talk about the scrotum. Okay, so here we go with the scrotum. Tell me what female anatomical structure is homologous to. Labia majora, only they don't have all the stuff in them. Okay, the function of the scrotum is primarily to protect the testes and to raise and lower the testes, in part because the testes do not do spermatogenesis at normal body temperatures. So if you want for spermatogenesis to go on, they have to be cooler than normal body temperatures. So what happens with the scrotum is it has, in addition to the skin of the scrotum, it has 2 layers of muscle. This is called the dartos muscle. It's smooth muscle. It just wrinkles the testes, wrinkles under the skin. This muscle is an extension of the internal oblique muscle, and it's called the cremaster muscle. And it's the one that raises and lowers the testes based on sort of temperature, but also based on stress, right? If it's really cold, they come home, right? It's really warm, they go wandering. Same thing with stress. If it's really stressful, they'll go home. If it's not, they'll go wandering. So this is the cremaster muscle, and then you move inside and deeper, and you'll find the testis itself. Okay. Oh, by the way, the scrotum actually has a separation that completely encapsulates one testis from the other, which is good because if you ever have a testicular infection, they're really uncommon, but they can occur. It's usually unilateral, and usually testicular cancers stay unilateral as well, which is good because most males with a single testis are still able to cause pregnancies. Go ahead.
How come things like testicular torsion still happen if they divide them?
It happens with one getting twisted within the inguinal canal. If it gets twisted within the inguinal canal such that it's compressing blood flow, then it can cause testicular torsion, which can actually kill off the testis if you don't take care of it. It's usually an anatomical anomaly that was during development. Okay, so let's look at the testis itself. Okay, so if you look inside the testis, first thing you can see is that it has this double layered membrane around it. This is really close to a serous membrane. It's actually an extension of the serous membrane. And it's called the tunica vaginalis, not because it has anything to do with the vagina, but vagina means fold. So this tunica vaginalis is got a parietal layer and then a serous layer, and then there's fluid between them. So there's hardly any friction. That makes sense? Same way serous membranes work elsewhere. And then if you move in from the tunica vaginalis, you can find the tunica albuginea, which they had in the ovaries as well. It's way thicker and more protective in the testes because they're way more at risk in the location that they are. This is really, really tough connective tissue. And then inside, it is packed with yards and yards and yards of seminiferous tubules. So what happens inside is it's divided into little segments like an orange. Each segment has tubes in it. It's called a lobule. And there are usually inside a testis around 250 lobules. Each of them contains 4 tubes that are all making sperm all the time. They are completely packed in there. Did you guys ever see when golf balls were made of rubber bands and you could slice into them and the rubber bands would squirt out? Did you ever see that? Okay. All right. So the first time I dissected a testis, first off, it wasn't a human testis. It was from, I don't know, deer, I think that we, okay. So I didn't have an appreciation for how packed they are in there. They are so incredibly packed in there that when I had gloves on, when I sliced into the testis with the scalpel, the seminiferous tubule squirted out, hit me in the freaking eye, right? So I've never dissected another one without goggles on, right? So if they are that tightly packed, can you see why they have tremendous sensory nerve endings? Because you can pop them. You can pop a testis. Do you know anybody who's popped a testis? They get like enormous, like this big when you pop them. Eventually they will heal, but that's why they are so sensitive to pressure, right? They're so sensitive to pressure because whatever you were doing, you need to stop doing it because it's really easy to pop them. It wasn't even hard to slice through it with the scalpel. So they're really packed in there. So what's going to happen inside the testis is inside each one of these seminiferous tubules, you are going to be doing spermatogenesis. So take a cross-section of one of those and look at the wall. Here we go. What we're going to be doing in each one of those seminiferous tubules is we're going to be going through meiosis, and then we are going to dump the haploid 23 chromosome sperm into the tube. And then what's going to happen is that 23 chromosome sperm, it's actually not active yet. The tail doesn't work yet. It's going to have to make its way from the tube through this efferent ductule through this, which is called the rete testis. Rete means net. And then it's going to have to make it into the epididymis. And then it has to spend about 20 days going through the maturation process in the epididymis, because during the maturation process, the tail starts working, okay? And during the maturation process, it gets a hat called an acrosome. The hat is super duper important because the hat has enzymes in it which will allow it to perforate the wall of the egg. Does that make sense to you? And the acrosome, or the hat, develops in this 20 days in which it moves from here to here. And the acrosomes are species specific. One of the things that we figured out about sperm, you can see is a little acrosome there. They've got little hats on, okay? One of the things that we figured out about acrosomes is that they have enzymes that seem to be specific to the wall of your species of egg, which is one of the reasons that even if two different species mate, it's very unlikely to cause a pregnancy. So let's say we've got a lion and a jaguar, right? They're both cats, but they're not super closely related. And if they mated, which they will quite often when you leave them together, will they usually produce a baby? No, if they're not super closely related, like a wolf and a dog, then the acrosomes won't work. So even if the sperm got to where it was going, it couldn't actually puncture the wall of the egg. So next time somebody tells you Bigfoot is from humans mating with gorillas, you tell them that the acrosomes would keep that from occurring, because we're not very closely related to any living mammal. Bonobos are probably our closest, and you're not going to run into those. Okay, so last little tidbit about the testes. Testes are, of course, supplied with testicular arteries and drained by testicular veins. They have tons of sensory innervation, and they have autonomic motor innervation. So let's see where you would go from there. Okay, so I'll take the last 2 minutes and talk about the epididymis. So when you're in the epididymis, it looks like sort of a little hat. Joe says it looks like a mullet, like the testis is wearing a mullet. You see, party in the front, or business in the front, party in the back. Okay, so the sperm, as it's maturing, is going to move from the head to the body to the tail, right? And then it's going to move into the ductus deferens or vas deferens. And the ductus deferens or vas deferens is going to have smooth muscle in the wall, and when a male is ejaculating, the smooth muscle contraction starts all the way from down there. Okay, so then it is going to go to show you the path of the ductus deferens. This is a posterior view of the male reproductive tract. So it's going to move from here up the ductus deferens. Notice the ductus deferens sort of folds around the ureters and forms the ampulla. This thing from the backside kind of looks like an angry mosquito, right? It's got angry eyebrows right here, and here's the eyes, and here's the proboscis of the mosquito. So it's going to move into here. And then what's going to happen is that during ejaculation, if you look at a mid-sagittal section of a male, so the sperm with just a little bit of fluid would be moving up the ductus deferens. Smooth muscle contraction would be going on. And then during ejaculation, the seminal vesicle is going to contract as well, and it's going to push into this ejaculatory duct. The ejaculatory duct will actually dump into the prostatic urethra, right? And then you're going to join with that with the bulbourethral gland, and then all of that stuff is going to end up in the semen. Does that make sense? Okay, go ahead.
At what time does the internal sphincter close?
It closes during arousal, not during ejaculation. Okay, I want to tell you something that I read this weekend in the research, because this is important. This is especially important for people who are about to become sexually active. One of the things that they figured out is that quite often, especially here in Utah, people use the withdrawal method, right? So let's talk about how effective the withdrawal method is. The withdrawal method is when you have vaginal intercourse with the male removes before he ejaculates. First off, people are not very good at that kind of timing, okay? So that reduces its efficacy by about 80%, or to about 20%, about 20% effective when you're using the withdrawal method. But here's one little tidbit that they figured out that will make you consider using a different method. And that is that the pre-ejaculate from the bulbourethral glands, which occurs not when the male ejaculates, but when he's aroused, the pre-ejaculate, okay, has sperm in it. Not all the time and not always very high concentration, but you can get pregnant just from the pre-ejaculate. So why would there be sperm in there? Well, because he's ejaculated before, right? That makes sense? So in Utah, they do this thing called docking, right? Where it's not sex if you don't wiggle. Well, it ain't fun if you don't wiggle either, right? Just stick the penis in there and just don't wiggle and don't ejaculate, and then you're not going to get pregnant, and also you don't need to tell anybody that you did that. Well, it's also a good way to get pregnant. It's less likely than if the male ejaculated, but it is possible to get pregnant that way. And apparently, if you do it absolutely perfectly, if you do the withdrawal method absolutely perfectly, and you get the timing exactly right, your likelihood of getting pregnant is still about 5 to 7%. So, but people aren't perfect, right? It's like a lot of human error. Okay, so today I will post the last little bit of this lecture for you, okay?